for a humeral shaft fracture, right? And once you take them out of the splint, you don't want to leave them there for too long because the shoulder is very prone to stiffness, right? Take them out of the splint a couple of weeks and put them in a sarmiento brace, which is that plastic contraption you see on the bottom right of the picture, and have them continue with range of motion. Physical therapy is always prudent very early on in fracture management, right? Particularly fractures about the shoulder and the elbow and the hand by extension. Now, in the event that you have to take them for surgery, you still want to splint the extremity, okay? And remember we said you splint because of soft tissue rest, you decrease motion, and it helps with your pain management, because pain in the presence of a fracture is not good, okay? Movement causes pain. Questions about this? Yeah. Right, stand by. I'm not sure if I mentioned to you guys, there is something called the 10% rule. Right? You have to be 10% smaller than your equipment. I am failing miserably. Okay. Fractures about the humeral head, right? So, what I want you to take away from this is that because of the way that the humeral head is constructed, you can have up to 4-part fractures in the humeral head. Okay? Pay attention to the anatomic neck versus the surgical neck. So, in that picture you see at the top, right? Right here. Okay, this is called the anatomic neck, right? The surgical neck is further down, right there between the metaphysis and the diaphysis. Okay, there are two prominent protrusions on the humeral head. One of them is the greater tuberosity, the other one is the lesser tuberosity. Who knows what muscles connect to the greater tuberosity? No, not the deltoid, you're close. If you can read fast, you might have seen it up there, but I don't want you to look, right? And if you don't know the name, you're absolutely right. What are those groups of muscles called? Rotator cuff muscles, right? So we have 3 that connect to the greater tuberosity, 1 connects to the lesser tuberosity, right? Okay. So it only stands to reason if there is a fracture of the greater tuberosity, there may be some sort of distraction, right? Because of the action of those muscles that connect at that insertion. Okay? So 1-part fractures, 2-part fractures are fractures that, for all intents and purposes, it's just a humeral head fracture at this location, right? When you have a 3-part fracture, what you have in most cases is a fracture above the greater tuberosity in addition to, right? So now you've got 3 parts: greater tuberosity, you've got humeral head, and then the rest of the bone. Okay? When there is a fracture that involves a lesser tuberosity, right? You've got fractures here, and then involved in the lesser tuberosity. Okay? In the case of 4-part fractures, you got all 4: 1, 2, 3, and 4. Guys tracking? Let's keep a cool eye on that track. I'm not going to ask you to go through and memorize the chart, but understand that there are 1-part, 2 parts, 3 parts, and 4-part fractures of the head. Okay? How do we treat these things? It all depends, right? In the case of the little old lady that fell on an outstretched hand and sustained said fracture, right, which is a very common occurrence, if they have no comorbidities and the fracture is non-displaced, right, they can be treated non-operatively. Okay? Those that we take to the operating room, especially are those that either are displaced fractures, open fractures, fractures in high performance athletes, that kind of stuff, where we want healing to be accelerated. Okay? But nonetheless, it doesn't matter. You still want to make sure that early range of motion about the shoulder is initiated. Okay. Scapular fractures. If you guys remember when we talked about scapular fractures about 4 lectures ago, maybe 3, I said that if you have this fracture about the scapula, it is a high energy fracture and you should look for additional injuries. Remember that? Okay. Therefore, when you see these things, make sure that you complete your head-to-toe exam to ensure that there aren't any additional injuries. If there is a fracture of the body of the scapula, that in itself tells you that it's tremendous force. That fracture, because of the orientation of that bone, it is not easy to fracture. Okay? But it does happen. So you can have fracture of the body, you can have fracture of the acromion process, you can have fractures about the coracoid, right? And you can certainly have fractures about the glenoid. Now, what structure articulates with the glenoid? The what? The head of the humerus, right? And there's a band of soft tissue that surrounds the bone, right? What is that for? I guess somebody's seen that, right? It's called the labrum, right? You've got the capsule, and then all of that is encased by the rotator cuff muscle. Right? Okay. Now, in cases where fractures involving the acromion, right? The fractures of the acromion, or even the glenoid. And if you have a corresponding fracture of the humerus shaft, then you get the perception, right? And we talked about the foot and shoulder, because you've got a joint and the bones on both sides of the joint fracture. If there is more than 2 millimeters of displacement, then just like we say for most of the other fractures, they need to go for operative management. Okay? We talked about some bones being able to tolerate a certain degree of angulation, right? In the humerus shaft, yes, we can. The glenoid, if it's more than 30 degrees, then it's amenable to operative management. Okay? Questions about that? So, key takeaway regarding the fractures of the scapula. Number 1, has to be high energy. 2, there may be multiple fractures of the scapula in said situation. 3, make sure you do a complete head-to-toe exam. 4, if there is more than 2 millimeters of displacement, particularly about the glenoid, then operative management. Otherwise, you can place that patient in a sling and they will be just fine. Okay. Fractures about the elbow. Now, we did mention that all the nerves and blood vessels that run from the shoulder and from the upper extremity that get into the hand and forearm, right? They all cross the elbow. So, it stands to reason that if you have a fracture about the elbow, that these structures can become compromised, right? Some more so than others. Okay? Fractures about the elbow are very common in children and very common in adults. Because most times that you fall, right, most people put their arms out to catch themselves, right? Nobody that I know of in recent history, if they're falling, just let them fall face plant, right? You always try to catch yourself. Okay? And that's why you end up with fractures and dislocations about the elbow and the wrist. Now, most times those fractures are posterior fractures, right? Or dislocations. So you have, as you fall, That shearing force pushes the forearm backwards, and you have a posterior dislocation. Okay? If events that you have an anterior dislocation, that is usually from a pulling force or traction force. We talk about, and I think I mentioned it in one of our other classes, is the terrible triad, right? If you have a patient that has a coracoid fracture, right? There's a coracoid process. Okay, so the reason I paused here, the last class, we had a lot of folks that were confusing where the coracoid and the coronoid are. Okay, do not make that mistake; it will cost you dearly. So, if you have a dislocation about the elbow, right? Dislocation about the elbow, it can impact the coronoid, right? Okay. If there is a coronoid fracture, a radial head fracture, and an elbow dislocation, that is called a terrible triad. It's an orthopedic emergency until you can prove otherwise. Okay, so that person goes into ortho. Okay, that one is not amenable to non-operative management simply because of the instability of that kind of fracture. Okay. So, coronoid fractures, radial head dislocation, elbow dislocation, and radial head fractures, terrible triad. Now, on imaging, you may see the dislocation, but you may not appreciate the other fractures, right? The radial head fracture may be displaced or non-displaced, and we'll talk about that in a second. If it's a non-displaced fracture and there's a dislocation, I would like you to assume that there is also a coronoid fracture as well, okay, until you can prove otherwise. What is the study of choice to confirm if there is a additional injury to the elbow? CT or MRI? CT. Why would you not use a bone scan? You're absolutely right, because it would be useless in this process, right? Yes. Okay. Now, this is not on your slide, but I want you to remember it. If there is a problem, about the elbow and the ulnar nerve is involved, right? Remember we talked about this in the last class? If the ulnar nerve is involved, then the patient may have what is called a positive Froment's sign. Froment's is that you have them pinch a piece of paper, right? And as you try to pull the paper away, the thumb is going to flex so they can maintain that pinch. Okay? Why is that? Why would you have, so remember we talked about the innervation of the ulnar nerve, right? So remember my statement, if you have a dislocation about the elbow and the ulnar nerve is involved, now you pinch it with the thumb and index finger, right? Why is it that an ulnar nerve injury is affecting what's going on the radial side of the hip? You can't maintain the pinch, but why? Weakness from nerve injury innervating which muscles? The adductor pollicis, right? Because the adductor pollicis, right? The adductor pollicis, it inserts on the thumb, but its origins are on the metacarpals of the ring and middle finger. Remember, the ulnar nerve innervates the small finger, the ring finger, and half of the middle finger, right? And that's where the origin of the adductor pollicis is. And so, because that nerve is injured, those muscles are affected, and then the flexor pollicis, right, that bends the thumb, gets activated. So, okay. The key takeaway is that patients with ulnar nerve injury, they may have a positive Froment's. Okay. something that gets missed quite a bit. Okay, how do we treat these things? Well, number one, you have to reduce the fracture, right, as best you can. And we talk about when you reduce a fracture, reproducing the force of the offending force, and then manipulation of the fracture back into its correct, the bone back into the correct orientation. Right? So most times, if you get the elbow at about 45 degrees and you apply some traction, it will separate whatever is hinging the distal fragment from the proximal fragment and get the elbow back into its place. Right? Depending on what else is going on, you may or may not see that coronary fracture. Okay? When you splint the elbow, you always want to splint it at 90 degrees of flexion unless that is contraindicated, right? For all intents and purposes, put the elbow at 90, right? And apply your splint. Now, the elbow is very prone to something called heterotopic ossification. I think Rich Davos talked to you guys about this. You know? You get a bunch of blank stares. You know he's at the back of the room. The level of disappointment on his face is astounding, right? Okay, heterotopic bone is just the outgrowth of additional bone in the face of injury, right? You see that a lot in combat wounds or any wounds that are about the elbow. Therefore, as that bone matures, it causes additional stiffness in the elbow. That's why you have to keep on moving. In a lot of cases, even with all that movement, the elbow still develops heterotopic bone. Okay? So just imagine there's all this fuzzy bone around the injury site compromising the movement. Okay? So range of motion is absolutely essential very early on in this. This is where PT becomes your best friend. Okay? If you cannot reduce the fracture for whatever reason, then they need to go see somebody who can. Okay? If you identify that there is a terrible triad, which is elbow dislocation, coronary fracture, and radial head fracture, right? Then we also need to go see someone. Okay. Fractures about the distal humerus, relatively uncommon in adults, but can be common in children, right? And we'll talk about that in a second when we get to the pediatric fractures. But the concern, as usual, for all fractures is the intra-articular nature of the injury. Okay? Any fracture that is intra-articular, particularly if there is a high degree of step-off greater than 2 millimeters, then those need to see someone that has a little more knowledge in managing those fractures. Okay? If you don't, then the adverse outcomes are continued neurovascular injury and, of course, compartment syndrome. Right? We did not talk about that. We'll talk about it more when we get into lower extremity fractures. But understand that there are compartments in the upper extremity as well, right? And forearm compartment syndrome is a real thing. Non-operative management for steel fractures and even occult fractures. You can splint them for a few days, right, 10 to 14 days, and then begin range of motion. Okay? The least time you can keep these folks immobilized, the better. For displaced fractures, intra-articular fractures, you want to get early range of motion after open reduction and internal fixation. Right? And again, if you don't manage these problems, then you develop nerve problems and all these sorts of things. Even when we repair these things, sometimes they have neurovascular problems, right? Or neural problems. Okay, let's jump into radial head fractures. These generally occur because of what we call a foosh injury, a fall on an outstretched hand. Okay? And in those cases, what you have is a posterior force of the radial head as it contacts the capitellum, right, of the distal humerus, and therefore shattering the radial head. Okay? Now, we mentioned the terrible triad with fractures of fracture dislocation of the elbow. When you get an X-ray of an elbow, right? A way you can tell if, number one, the x-ray is a good x-ray, or two, if the radial head, or if the elbow is dislocated, is whether or not this radial head lines up with the capitellum, right? So a good radiology tech will ensure that they give you the right picture. But if you look at the x-ray and that radial head does not line up with the capitellum, that's a problem, right? There are three types of radial head fractures, type 1, 2, and 3. We'll cover some of these on the next slide. But remember that non-displaced or minimally displaced fractures, usually not big of a problem as if they were displaced or comminuted. Okay? So type 1, non-displaced or very minimal displacement. Type 2, they're displaced more than 2 millimeters, right? So you see the pattern, right, with this whole 2 millimeter thing. And then type 3 fractures are those that have multiple marks. Okay? When you do your physical exam, always make sure you check for neurovascular compromise. One, if there's a joint effusion, in some cases you actually have to aspirate the joint so you can get that patient to move. It's amazing how that works. Okay? If there is a block to motion for whatever reason, okay, so you do what we mentioned earlier. You perform a hematoma block, right? You inject some anesthetic into the elbow to get the elbow to move, but somehow you cannot move the elbow. So you take away the pain factor, right? And now you have the patient try to move that elbow, and that elbow will not move. That means something is preventing it from moving. Okay? It could be either innerpost tissue, or it could be that there is a fracture. If there is a radial head fracture and there is fracture of the or disruption of the interosseous membrane, right? And that's all at the elbow, right? So that interosseous membrane runs from the elbow all the way down to the wrist. Okay? When it gets to at the level of the wrist, there's something called the distal radius ulnar joint, the DRUJ. Okay? If there is injury to DRUJ, you have too much movement at the wrist, right? It becomes compromised, and that becomes even more of a problem. So radial head fractures with interruption of the interosseous membrane and problems at the wrist, that's called an Essex-Lopresti fracture, and not good. Okay? These usually have a very unstable and need to be seen by orthopedists. Okay? So for type 1 fractures, you can put them in a splint, always early range of motion. Okay? Those fractures are generally non-displaced, as we talked about, or minimally displaced. Right? Type 2 fractures, if there is less than 2 millimeters of step off or displacement, you can also treat those non-operatively, but only if there is no block to motion. Okay? And then type 3 fractures, those are the ones that are comminuted, or you've got complete separation of the radial head from the shaft, right? Those need to see someone that's got some skills. Okay? In type 4 cases, just talk about that. That's the ones that are the terrible triad, because there is a dislocation and a radial head fracture, right? Get those, absolutely, you'll need to see somebody. Okay, any questions about radial head fractures? Are you guys getting all this, or are you just ready to go home and same here. No, I gotta be here for something later. Okay. Let's look at fractures about the metacarpal, right? Metacarpal and phalangeal fractures. We're going to cover these in the next couple of minutes. Now, key takeaway from this, right? And you may have seen some of this before. The difference between fractures of the thumb metacarpal are determined by whether or not they are 2-part or 3-part fractures. Okay? Bennett's fractures are two-part fractures. Rolando fractures are three-part fractures. Okay. They're both treated differently, as you can imagine, which is why they are potentially named the way they are. Okay. We can go into why you get the two-part and three-part fractures. I think that is probably borderline a little beyond the scope of this class, but it's something that you can certainly read upon. And it all depends on the pull of the abductor and the adductor muscles and their attachments. Okay? But the key takeaway from this, what I want you to remember, is that the Bennett's fracture is a two-part fracture, the Rolando fracture is a three-part fracture. And in the cases where these fractures are not treated well, because of the importance of the thumb to your hand function and the development of post-traumatic arthritis, that can be a big deal. Okay? There is an entire subspecialty of orthopedics dedicated to the hand. You will not become a hand ortho specialist in 2 lectures. Okay? Just like there is a whole set of foot people, there's a bunch of hand people. Okay? I think this is the only subspecialty in ortho that actually sits down for the whole case. Am I correct? Yeah. So if you do ortho and you want to sit down for the whole case, be a hand guy. It takes forever to do these hand cases. Okay. If you lose the function of the thumb, right? If you lose the function of the thumb, all you've got is just a minute, right? Because the thumb does everything that's for you. It's the one that the adduction and flexion and extension of the thumb is really what makes the hand a hand. Otherwise, it would be just functioning like a foot, right? So the thumb is important, and so you got to be careful when you have issues with the thumb to call someone, right? Because when a patient loses that function, it can be very debilitating for them. Okay, so non-operative management in Bennett's fracture, that is generally the way to go, because most times, right? Most times these fractures tend to be displaced because of the actions of the thenar and hypothenar muscles. Okay? So, non-displaced Bennett's fractures are not very common. Okay? These things are rare. Why? Because again, these fractures tend to pull apart just because of the way the muscles are acting. Okay? And so if you get a fracture about a patient that comes in with trauma to the thumb and they are painful at the CMC joint, I want you to err on the side of caution, put them in a thumb spiker splint. We'll talk about that during the split class until you can get some extras. Okay? Do not just assume, it's just your CMC joint, right? Just go ahead and mobilize it for a minute and get your films, and then you can go on from there. Rolando fractures, right? Remember I told you Rolandos are three-part fractures, so those all go to the operating room. If there's a displaced Bennett's fracture, obviously, like I talked about, these get seen as well. How do we repair these? Well, we put them in a cast, depending, or we can open them up, put some little tiny clips and screws in them, or we just put some pins through them to hold the fracture fragments in place until they heal. Okay. Let's talk about other fractures of the hand, right? The pisiform bone houses a small protrusion, right? Houses a small protrusion, okay? And between the pisiform and the hamate, this little outcropping thing called the hook of the hamate, okay? That little canal is called Guillen's canal. And through Guillen's canal runs a branch of the ulnar nerve. So, For people that play repeated racket sports, okay, for people that play repeated racket sports, in a lot of cases, there is fracture of this little bone causing impingement on that branch of the ulnar nerve, and then you have ulnar neuropathy. Okay? It's a lot more common than you think. There was a time when the Army was very big into racquetball. Like every gym had a racquetball court. It's great. It makes you sweat, right? This is for you guys. So now they've all replaced it with Pilates or some kind of exercise. But anyway, let's digress. And so we would see a lot of these, right? Because folks were in there playing racquetball, right? Now we got into handball and tennis, baseball. You may see some of these as well. What more? Oh yeah? I heard about it. Doesn't sound very enticing. Maybe it is, I think you should try. And then pickleball players in there? Don't be ashamed now that I said that, you know, right here. Oh yeah. You do?
Me and my church played a lot. Me and my church played a lot. It's like ping pong, but like on a tennis court.
Ping pong and tennis court. Sounds like a travesty already. Now I gotta go Google it. Alright, well, this one, I think it works first. Alright, so in the case of ulnar neuropathy, right, what would you expect to find? The patient with a hook of the hamate fracture and ulnar neuropathy, what kind of symptoms would they have? Paresthesia where? Along the ulnar nerve distribution, right? Okay. Muscle wasting where? Yes, and what is this thing called? Nope, that's not the femur. And all right. I know the knowledge is in there somewhere. You just gotta tease it out. And, hey, as long as you can resurrect it next week. Now, how do we treat these things? Okay, we'll put them in more than likely an undercutter splint, right, until and probably cast them later on if that's the use of work. In the case where this thing continues to create problems, then we just get in and take it out. Right? That's the operative piece. Okay, let me take this moment to remind you something. In your clinic, there may not be casting material. So we talked about casting here and there, and speaking to you. Most times you find that at the ortho clinic, right? There may be some, if you learn casting, excellent skill to have, especially in the deployment environment. But the way we put cast on and the difference between a cast and a splint is that one is removable, readily removable, one is not. One is circumferential in most cases, the other one is not. So you splint them, same kind of mechanism, and then you just wrap it. And we'll show you how to do the splints downstairs and show you the difference between splint and a cast. So I may be using, you put them in a cast, sort of interchangeably with splinting. It's just the immobilization is what I want you to take away from it. Okay. Distal radius fractures, very common, probably one of the most common fractures, particularly for the elderly that tend to fall back, right? They tend to break their wrist. In a lot of cases, you see, osteoporotic women that maybe fall and break a hip. In a lot of cases, the hip actually breaks the adaptation force, right? It weakens, snaps, they fall, put their arms out, and so they end up with a fractured hip and a distal radius fracture. Okay? That's relatively common. Because of the orientation of how we try to prop ourselves up when we fall, then you end up with an apex volar fracture of the distal radius. Okay? It's called a Colles fracture. These fractures are extra-articular, which means that the break is not necessarily in the joint, right? It's somewhere between the metaphysis and what would be the diaphysis of the bone. Okay? So, key takeaway, Colles fracture is a distal radius fracture that is apex volar. Right? Does anyone not know what that means? It means that when the patient holds the hand up, right? They hold the patient's hand up like this, and it's fractured. This is the orientation you might see because there may be the ends of the bones are right here, as opposed to apex dorsal, where the ends of the bones are on the back of the head, right? I do not know too many people, if you're falling from height, put your arms out like this to stop yourself. Somebody does, because obviously there is, okay? But there are instances where people do get injured like this, right, for one reason or another. That's called a Smith's fracture or a reverse Colles fracture, because it's the opposite of what you would do if you fell on an outstretched hand. Okay? So, again, these fractures are extra-articular, right? Doesn't involve the joint. Can you have a Smith's or a Colles fracture that is also intra-articular? Short answer is yes, right? And we see these very often. Or I should say a distal radius fracture that is intra-articular, right? The Smith's fracture and the Colles fracture, by their definitions, are extra-articular fractures. But you can have distal radius fractures that are intra-articular, as we see here with the Barton's fracture. Okay? The other thing that you have with these type of fractures is, in addition to the intra-articular nature of it, you also have some sort of subluxation or dislocation of the carpal bones. Do you think this fracture is amenable to non-operative versus operative management? Operative, right? Especially if it's that displaced. A Schaffer's fracture is just a fracture of the radial styloid. Okay? Most times, it's an oblique fracture. In some cases, it can be a transverse fracture as well. Die point fracture is an impacted fracture of the carpal bones on the distal radius. Okay? And just creates an indentation in the bone, or in the cartilaginous portion of the bone. Yes.
Is the Schoffer's fracture also a Barton fracture?
Is the Schoffer's fracture also a Barton's fracture? Here is a Barton's fracture, right?
Is that fracture right there?
So, so his question is the Schoffer's fracture a Barton's fracture? So the Schoffer's fracture can be, that's a good question. Never really referred to it as it's a Schoffer's fracture.
So my definition, you might go into the Schoffer's. So my definition of Schoffer's fractures is a radial styloid fracture. So you guys see that little area where the radial styloid is, where the fracture is? So that is a Schoffer's fracture, right? But that's another reason why we keep telling you guys, or I told you guys at some point, we don't like these even-ends, right? Yeah. Because one even-end may not capture the entire fracture pattern. So if you call me and tell me you got a Schoffer's fracture, I'm assuming I'm just going to see that. But then I get the die punch component to it too, right? So then is it a Schoffer's fracture or a Barton's fracture? It's neither. Make sense? But what you guys need to know is the Schoffer's fracture is a radial styloid fracture. Barton's fracture is something that's intra-articular in nature, and usually is more towards the interosseous side, right? So maybe towards the upper side. Make sense? That's what you.
Yeah, we generally don't consider the styloid of the radius as intra-articular because it doesn't not communicating with another bone, it takes part of the joint. Yeah. Good question. Never thought about that.
Probably don't use the internet.
Yeah, exactly.
But you guys need to know this for pants, because they're gonna ask you stuff like that.
Yes. All right. Any questions about that? Okay. Good question, by the way. Well, I got to read the book. So, okay, Boxer's fractures, right? Very common in our population. In young, healthy males, that's where you lose a fight with a wall locker, a wall, or someone else's feet. What you have in a Boxer's fracture is a fracture of the shaft of the fifth metacarpal. It is probably, in some populations, the most common fracture. This is a fracture that results from people not knowing how to throw a punch, and even when you do, because you never punch with the pinky side of your hand. Who does that? Apparently, a lot of people do, because we end up with a lot of these fractures. Okay? Now, the distal part of the radial, the fifth metacarpal hand, and we can, I don't think we're going to go too deep into this, but the fifth metacarpal head can be angulated, right, as a result of this fracture, and throws the phalanges out of orientation. And so you get rotation, right? You see it here on this finger, but you might get this type of rotation in the small finger as well. Okay? So sometimes, if you want to check finger rotation, have the patients hold the hands at the IP joints, right? And then you see whether or not the fingers all line up. They should all line up towards the metacarpal crease. If they don't, and you see that one overlaps over the other, then that's a sign that they're rotating. Okay. In cases where you have fractures of the phalanges, then there is some rotational components to them as well. Okay. When we get to the lab, if we have the time, I will show you how the weakness of some of these joints as you break the hand tend to break things a lot. You might have some time to see some real pathology. Okay. Let's see. Now, when you're doing a physical exam of the hand, okay, and we talk about it some more, you always do your neurovascular exam. Okay? So check for sensation, check for motor activity, check for capillary fish. So, how do you treat these fractures? Well, if a Boxer's fracture has less than 10 to 15 degrees of angulation, then you can treat it non-operatively, right? If there is no extensor lag, which means that as you try to extend the fingers, right, the normal orientation of your hand is like a slightly curved posture like this, with the wrist slightly extended. Okay? You have the patient try to extend the hands, and in cases where you will see that slowness in the extension of the digits, then that tells you that there is something else going on, right? Typically, it's neurological. You can place them in an unlocked splint for a couple of weeks, but if there is more than 40 degrees and there is extensor lag, then that becomes an even greater problem. Okay? There's a reason that we try not to cast the hand or spin the hand for too long, right? Because again, fingers are very prone to stiffness. And so when you get a Boxer's fracture, right? When you get a Boxer's fracture, and I don't know if you guys can see very different picture, but you see this fifth metacarpal, and it may be angulated a little medially, right? Fifth metacarpal may be angled a little medially, right, at the fracture site. If that is greater than 40 degrees, right, then reduction is certainly necessary, and They cannot and should not be casted, right? That needs to be reduced from sent to the OR. If there is displacement of the fifth metacarpal, which means that the bones are not adequately aligned, then certainly that's an operating management as well. If it's intra-articular, and in this case, we're talking 1 millimeter of displacement intra-articularly, right? We're talking about 2 millimeters for the other larger joints, right? 1 millimeter of displacement, then certainly that should be an operating management. Okay. The key takeaway that I want you guys to remember from this slide, okay? When we talked about the buxus fractures, one is very common. If it's greater than 10 to 15 degrees of angulation, greater than 10 to 15 degrees of angulation, then it needs to be referred. Okay? I see some of what else is on the slide. Disregard that. Clean that up for the next class. How do we repair these? You can either do with percutaneous spinning, right? The things that we put in just through the skin, keep the fracture fragments in place, and or we can put tiny plates and screws. Scaphoid fractures. Any questions on buxus fractures or hand fractures? Okay. Scaphoid fractures. I told you that there are watershed bones in the body where the blood supply can be a little tenuous, and the scaphoid is one of those bones, right? We divided the scaphoid into different sections, okay? The mid portion of the scaphoid is called the scaphoid waist. And because of the tenuous blood supply at the scaphoid waist, it can be amenable to osteonecrosis, right? One other bone in the body that's also prone to osteonecrosis, human neck, right? We talked about the human head, right? Okay, so let me get your attention, undivided attention. Here's what happens with patients with scaphoid fracture. Sometimes they know it, sometimes they do not. So the patient will present to you with anatomic snub box pain, right? You guys know where the snub box is, right? Okay. Why is it called a snub box? Okay. You guys know these things. Okay, so when they present with snub box pain, right, and that's all they have. You take an x-ray, and the x-ray is normal. So what do? Okay. So you could splint them, right, wait a few 7 to 10 days, have them come back in a week, and then you re-x-ray them. Why is it that a patient with an occult fracture, if you re-x-ray them a week later, that you may see a fracture line? He said lack of collateral circulation, so the fracture line shows up. You agree? What do you think? Yes.
I would not agree with that.
You don't agree with that one? Okay. What's your best guess then? Why does a fracture line show up 7 to 10 days in an occult fracture? Inflammation subsides, but then what happens? What else happens as the inflammation subsides and the body tries to heal itself? Then what? Tries to reestablish circulation, tries to deposit more bone, right? Remember from physiology, you had the osteoblastic activity, osteoclastic activity. So it starts developing new bone. That new bone is what shows up as a fracture line at the fracture site, right? So, in cases where you think there may be a fracture, but there is none, some wait for a week, right? Some wait for a week, re-x-ray, and you may see a fracture line. Okay? Now, in cases where they come back a week later, they are still painful, but there is no fracture line. Then what? MRI. Get an MRI, right? Why MRI and not a CT scan?
still sensitive for it? MRI is more sensitive for it?
It's more sensitive, yes. And you can get it may show up on a CT scan, right? MRI is just a better slit. Okay. So that's how you treat occult scaphoid fractures. Now, in the event where they show up and you put them in a cast or a splint, or they've been in a cast, you get an MRI, you identify that there was a fracture there, they go to orthopedics, they get casted. Now it's about, 6-8 weeks, cast comes off, patient thinks he's doing well, shows up again 3-4 months later with continued pain, right? What's your next step? So you can refer him, yes, but assuming that you don't have that option. So you said MRI, right? Why? Because you checked it for osteoporosis. You guys hear that? Right? So you repeat the MRI, and this time you look at something different. Right? Okay. That covers everything in these next steps. Let's talk about the pediatric elbow. Now, most pediatric elbow fractures are because of a fallen and outstretched hand, right? Summertime, springtime, fall, kids love the monkey bars, and they just come in all types of elbow injuries. Okay? It is the most common fracture in that young population, all the way up to 12 and the preteen years. Okay? Now, they have fractures of the distal humerus. They have lateral condyle fractures, medial condyle fractures, and I think the supracondylar fracture is perhaps the most common. So, we talked about in a previous elbow class, we mentioned that the radial head must always line up with the capitellum on your radiographic film, right? It's more important to remember that when you're treating kids because the bones are not fully ossified. Okay? Whenever there is a potential, when there's a potential elbow or supracondylar fracture, you will see one dark line at the posterior aspect of the distal humerus and one in the front. Okay? Here's what I want you to remember about this. This is called a fat part sign or a sail sign. Sail sign because it kind of looks like a sail, right? You guys are not seeing what I'm pointing at, this thing right here. Okay. An anterior fat part sign is generally always there, right? It's not a bad thing. If you see one, don't raise any red flags. Posterior fat part signs are generally never there in a healthy elbow. And so, if you see one, you have to suspect that there is a fracture about the elbow. Okay? So, a posterior fat part sign or a posterior sail sign is an indication of hematosis and potential elbow fracture. Okay? How do we treat these things? Well, if they're non-displaced, you can put them in a cast or in a splint. If there is fracture about the radial neck with less than 30 to 45 degrees of angulation, you can also put them in a cast or splint. Okay? You shouldn't make a habit of referring any potential supracondylar fractures. Okay? For all intents and purposes, if you see one and the radiologist suggests that they may have a supracondylar fracture, just refer them to ortho. These are generally amenable to surgical management. And in most cases, we just either cast them or use some percutaneous clinic. We talked about clavicle fractures in the adults. Let's talk about clavicle fractures in kids, right? So newborns and infants, right? They sustain some trauma during childbirth or shortly after childbirth. And so those tend to heal without any problems at all because these young ones are very pliable. Okay? Now, in younger children, you can put them in that figure of 8 brace that I told you that adults tend to not tolerate very well. Okay? That seems to work very well in young kids going all the way up to about 8 or 9 years old. If there is some sort of shortening, right, and 1 to 2 centimeters of shortening, you can put them in a sling. A lot of clavicle fractures can simply be treated in a sling. Okay? If they can't tolerate the figure of 8 and they don't want to operate manually, a sling usually does well, unless there is stenting of the skin and bayonet apposition, right, or shortening. So, for kids with young kids or babies with proximal humerus fractures, all you do is you pin the arms of their little onesies onto the body, and that usually takes care of it. Okay? They're young, and they tend to heal very well. Okay? In younger kids, you can actually tolerate more ambulations. Remember in our first class I told you might see a kid with long bones that seem to be very angulated. You treat them non-operatively, and as they heal, then things just tend to straighten out. In adolescents and older adults, you can certainly use the hanging calves. They don't tend to tolerate those braces as well. And so we kind of do things that we apply modalities that we know that the patient can be compliant with. Okay? Now, if reduction is needed, then we can tolerate 30 to 40 degrees of angulation. In other cases, they cannot, and then they'll have to go to surgery. Okay? Fractures of the distal forearm. So, most pediatric fractures, in addition to supracondylar fractures and elbow fractures, are fractures of the distal forearm. And in a lot of cases, those are both bone forearm fractures, right? Based on the age of the kids, there may be, you may see some buccal fractures. And remember, when we define a fracture, it's simply a disruption in the cortex of the bone, right? And so these buccal fractures will only present as a nice little bump on the cortex of the bone, or you see something that doesn't look right? The smooth lines of the bony cortex is somehow missing, right? So when you see these, always place them in a splint or send them to get some casting. Distal radius fractures that involve the dislocation of the distal ulna, right? Especially if it's a both bone forearm fracture, that's called a Galeazzi fracture. Again, just another term, and to Rich Douglas' point, better to just be able to describe the fracture rather than, you know, trying to name it. Treatment. In most cases, pediatric fractures, if they are within 7 days of injury, then we can try to reduce them, right? So if you see these fractures, you put them in a splint. If you work in an ER or in a clinic, put them in a splint, they can wait a few days. That fracture is not going to heal in a week, right? So we can still manipulate them at that point, even for adults, right? Still manipulate them and get them to looking at these semi-right, okay? If there is a rotational component to the fracture, especially in a both bone fracture, you want to be sure that you do your neurovascular checks, because that very nature of the rotational component may compromise the vascularity of the extremity. If there is none, then of course you can go ahead and spin them in that orientation. Galeazzi fractures, right? We talked about those. Both bones with dislocation of at the distal ulnar joint. So those have to go to ortho for management. Okay? If the angulation remains greater than 15 degrees, then certainly then they need to be treated in the operating room. Right. A couple of other fractures that you may see on your pants exams later on. One of them is, we talked about the both bone forearm fracture, which is a fracture of the radius and ulna. The Montague fracture is an ulnar fracture with radial head dislocation. And of course, I think mentioned earlier the Essex Sopresti fracture, which is radial head, interosseous membrane, and the distal radius ulnar joint involvement. Okay. Questions or comments? So, we talked through quite a bit of fractures of the upper extremity, right? If you're paying attention, I told you the things that I wanted you to remember about these fractures. However, nothing stops you from picking up your book and reading some more about each one of those, right? The more you know about it, the better you understand it. I think the better you're doing practice, okay? You see the list of fractures up there. If you have any questions about one or more of these conditions, please raise your hand. I'm hearing nothing but crickets. Okay. I will be around for the greater part of the morning into the afternoon if you have any questions. If not, as you're studying this weekend, right, like I said earlier on, I am here for you. If you text me on Thanksgiving Day because you